Spend about 15 minutes going over proning in spines theatres. And what I'm going to do is focus specifically on the Allen table and proning in spines. And at face value, I think it sounds like quite a niche topic, but it is quite important because it affects all of us who do regular spines or irregular spines. And that's basically everybody who does any general on-call at NUH, because spines emergencies come out of hours, and often when those ones do, they can be unstable or difficult. And so in this situation, the Allen table is really useful for proning and will be a great friend if we know how to use it properly. So Helen Fenner, Kevin Tate and I have been working over the last 18 months on some resources to try and help with this. And so what I'm going to do today is just remind you about how to use the Allen table, also to try and draw your attention to the resources that are now available and some which are up and coming. So a bit of background to begin with. And for those not familiar, this is the Allen table, and it's used for surgery in the prone position in our trust. It's mainly found in spines. Its design, as you can see, is quite different from a conventional operating table. But for us, I think what makes it really unique is this mechanism for which you can use to prone people, which we're going to call sandwich flipping. And I'll show you what that means in a moment with a video that we've made. And when we started doing this work, we conducted a survey of all the anaesthetists in the hospital at the time. So that was consultants and trainees and those who did regular spines and also those who didn't. And this was one of the questions. So you're asked to sandwich flip a patient on the Allen table for an unstable spine. How does it make you feel? And you can see that most people tend towards the uncomfortable end of the spectrum. And the comments were mostly about lack of experience and lack of training in doing this maneuver, which is why I'm here today. And the other big question is, why should I bother doing this? Because we can all prone patients by rolling them over and catching them on the operating table. And in fact, that's probably what we're more used to. So what is it that makes this important enough to warrant some time at the divisional day and extra training? Well, the first is that it keeps the spine in alignment. Because when we just roll them patients over and catch them, no matter how careful we are, there will be a movement of the spine out of alignment. The second is that proning patients by rolling and catching them, even when you have 3 or 4 people each side, it's still a hazard to our own spines. And so the department can't really afford any more sickness. And also we don't want to be having spinal surgery ourselves if we can help it. The last thing is, if I draw a parallel with a difficult airway, and there's no point just cracking out this piece of equipment once in a blue moon when there is a critically unstable spine, because we just won't have the familiarity to do it safely. And if we do that, then all of the potential benefit of it is lost. So there's now a whole series of resources that are available to help you. On the intranet, there's an SOP for how to sandwich flip patients on the Allen table, and contained within that is a checklist, which you'll also find laminated in the spines emergency theatre. And we've created a video as well, which I'll show you in a moment. And hopefully that should soon be accessible from the Trust computers, I think probably via the Learn with NUH channel. And that will be a good quick reminder for you, particularly, let's say at night before you need to do this for real. And then also this morning running some workshops in Theatre 6 at Queen's so that you can have a go. And in the pipeline, some more generic guidelines about proning and dealing with emergencies, and how to use other prone equipment like Montreal mattresses or bolsters. So as I mentioned, this is the SOP on the right-hand side, and you can find it if you just type proning into the search bar on the intranet. I think it's about the 4th one down. And this is what the checklist looks like. It's double-sided, it looks like quite a lot, but when you just read through it, it's fine. And in a similar way to how a cardiac arrest team leader stands back and doesn't touch the patient, we would advocate that the leader of the proning just stands back, make sure everything's done properly, and just reads out from the checklist to make sure all the steps are completed. Well, I'm going to hopefully try and show you the video that we've made now, so just bear with me a second. This video describes how to perform a 180-degree flip using an Allen table. This procedure is helpful, particularly in patients with unstable spines. Where possible, all anesthetic lines should be placed on the same side, as this will determine which direction to flip the patient. Attach the Mayfield clamp if you're using one. Pat slide the patient onto the Allen table's supine support. Make sure that the patient is as far down the table as possible, as this will allow easier attachment of the Mayfield clamp. Secure the arms using the arm retaining strap. Attach the H-bars to the Allen table, top and bottom, using the long T-handled pins, which should all be inserted in the same direction. Place 2 pillows over the patient's lower legs. Align the prone frame over the patient and attach to the Allen table through the top holes using the long T-handled pins. The chest, iliac and thigh supports should be properly aligned. Attach the Mayfield clamp to the Allen table using the angled attachment. And the patient should be compressed snugly between the 2 Allen table frames. And the anaesthetist should confirm that the airway pressure is acceptable at this point. Using 4 straps, secure the 2 frames together. Strap release should be positioned so that they can easily be accessed following the proning process. The IV lines should run over the top frame and determine the direction of the turn. IV lines do not need to be disconnected, but if you are inexperienced, then you may wish to do so to prevent them from being accidentally dislodged. When ready to prone the patient, identify who will lead the flip and who will perform the flip. Identify which direction the flip will occur. Generally, the arm with the IV access will go over the top of the Allen table, so a left arm IV access will go over to the right. Check, are all the 8 pins inserted?
Check, are all straps on and secure? The strap releases should be in an accessible position. Check, is the catheter bag secured so as not to snag on the turn? Check the patient monitoring leads position so that they will not snag on turn, and if in doubt, disconnect. While stabilizing the Allen table, release the manual flip handle, which is the red switch, and the handle should now be in the down position. Verbalize the flip countdown and direction. Disconnect the breathing circuit. 1, 2, 3, and then we'll turn after 3. Yeah. Hit disconnect the breathing circuit. Ready then? 1, 2, 3. Perform the flip and lock the table. The manual handle should be returned to the upwards position and the manual light should now be switched off. Recommence ventilation. Attach arm boards if using. And finally, remove the Allen table frame. And position the arms.
Hopefully that played well and just gives you an idea of what the sandwich flipping mechanism is like. So that's all I have. Thanks very much for your time. And if there are any questions or feedback, then please let me know. And otherwise, we'll hopefully see some of you soon.